All right. Hi, my name's Aditya Mittal. I'm a medical student at the University of Pittsburgh, and I'm working with the Cerebral Aneurysm Research Group to commercialize a simple blood test to detect cerebral aneurysms. So a cerebral aneurysm is a dilation in the wall of a blood vessel. This can push on nearby structures causing neurological deficits, or it can rupture causing a subarachnoid hemorrhage or brain bleed. I want to start with a patient I saw in the ER. She was a 46-year-old woman, a mother. She came to UPMC Presby with an intermittent right-sided headache for 5 years and associated nausea. She received various lab work and imaging to rule out common causes of her symptoms such as migraines, infection, hypertension, and she was eventually diagnosed with a cerebral aneurysm. So the surgeon walked into her room and explained to her that unfortunately the aneurysm was not at a stage where it could be treated yet. She was sent home and told to wait 6 to 12 months until following up again. About 50% of all patients endure this watchful waiting period. The patient returned a month later with the worst headache of her life. Her aneurysm had ruptured, she went into a coma, and died a few hours later. As a medical student, I was shocked that she could be sent home with a ticking time bomb in her head and have no idea when it was going to explode. In my opinion, this is a preventable death. About 5% of the general population has an aneurysm. 50% of the patients that rupture will die before ever reaching the hospital. 1/3 of the patients that survive will continue to live with severe disabilities. I was curious why this patient didn't receive more continuous monitoring, and this really boils down to 2 major pain points. It's invasive. The gold standard for aneurysm diagnosis is digital subtraction angiography, or DSA, and it's an invasive procedure. Second, it's expensive. The average cost for aneurysm diagnosis ranges widely, but it averages about $90,000 to detect a single aneurysm. Now I want to walk through the clinical paradigm that the patient had went through in the ER. She was first suspected of having an aneurysm. Then she obtained a DSA angiogram or MRI for diagnosis. Then she underwent the watchful waiting period where she received a CT angiogram or MRI every 6 to 12 months. The gaps in continuity are where the skulls indicate she could slip through the cracks and rupture. So let's say she survived. She would then receive a preoperative CT angiogram or MRI, undergo surgical treatment. There's also a risk of aneurysm recurrence and rupture going undetected during the postoperative follow-up, with imaging only occurring once a year. There is no simple, non-invasive test for cerebral aneurysms. Therefore, I would like to introduce the cerebral aneurysm test, or CAT-7, the first simple blood test to detect cerebral aneurysms. CAT-7 is a 7 cytokine panel that gives you a yes-no answer if you have an aneurysm, provides risk stratification and probability of rupture if an aneurysm is detected. CAT-7 detects aneurysm formation in a preclinical animal model and human samples at a high rate, and it's able to differentiate between cerebral aneurysms and other aneurysms in the body. Ultimately, this will reduce costly or invasive scans for the patient. And below is a diagram. You collect the blood test, input it into the cytokine array, receive a yes-no answer if you have an aneurysm, and if it's yes, you'll receive the corresponding inflammatory profile. So above was the current clinical paradigm, and below you see the CAT-7 paradigm, where all of the green markers show where CAT-7 can be integrated. Before, we had these gaps in care during the watchful waiting period. CAT-7 completely eliminates any patient falling through the cracks and rupturing during the watchful waiting period and follow-up. Additionally, the risk of rupture metric can be tracked over time to predict when a patient will rupture and optimize treatment for that patient. So we plan to initially target the watchful waiting patient market, which is 3.25 million potential positives, and then expand to the asymptomatic screening market, which we suspect is a larger market. We estimate the cost of goods is $70 per CAT-7 test. Medicare reimburses $770 for an analogous blood test that measures inflammatory markers. Private insurance averages $90,000 total for the diagnosis of an aneurysm. This includes multiple imaging modalities. So based on these values, the revenue for the symptomatic patient cohort is estimated at $63 million per year. And if we expand that to a one-time screening of family members, we have an additional $45 million per year. Remember, insurance reimburses more when a rupture happens, but reimburses less when a rupture does not occur. Therefore, there's an economic benefit to reimburse this test. So far, we've obtained external funding of $51,000 and internal funding of $18,000 and filed the patent application for CAT-7. We are currently finalizing the retrospective data, and then with the support of the McGinnis Award, we'd be able to conduct a prospective clinical study and apply for additional NIH funding. We will then begin commercializing the product through a CLIA lab pathway, and then an FDA pathway a year after that, pursue an FDA approval, and then ultimately conclude with a multi-site clinical trial. Alongside me, we have an excellent leadership team of clinical research and computational expertise with Dr. Kamil Nowicki, who's a chief neurosurgical resident and junior endovascular fellow at UPMC, Dr. Alattar, who's a third-year neurosurgical resident, and Dr. Robert Friedlander, who's the chairman of the Department of Neurosurgery and the project mentor. If we were to win the top prize, the majority of the money would be allocated to the human and mouse cytokine arrays and ELISA kits, which would give us a quantitative measurement of the cytokines that are expressed. You might be asking yourselves, why now? And that's because Dr. Nowicki and I will both be taking research years next year. We'll be working full-time on developing and commercializing CAT-7. With a $25,000 award, we'll be able to increase our sample size to 50 humans and 50 additional mice, which would give us the appropriate statistical power to say that this test works and approach VC funding. In summary, CAT-7 changes the aneurysm diagnosis paradigm from costly invasive testing to inexpensive lab testing. CAT-7 decreases anxiety for patients during the watchful waiting period. And CAT-7 saves the lives of asymptomatic patients before they rupture. Cerebral aneurysms have been treated the same way for the past 100 years. It's time to move treatment and diagnosis into the 21st century. Thank you.
So it's pretty inconceivable that the standard of care was to just wait.
Right.
So you must have had some sort of breakthrough in your diagnostics that you were able to, so do you want to talk about that a little bit?
Yeah, of course. That's a great question. Other approaches have failed. Well, obviously people have tried to do this, right? A blood test would seem intuitive. And other approaches have failed for two main reasons. First, they used a single biomarker, and they treated aneurysms as almost as like homogeneous, a single entity. And we flipped those on its head. We said, instead of a single biomarker, that's not specific enough, we need a cytokine fingerprint. And the second assumption that we flipped was that aneurysms are guided by chronicity. They express different inflammatory markers depending on the stage that they're at. So we've created 3 different profiles: an acute, chronic, and impending rupture aneurysm. And we're able to diagnose those and detect those with a high rate of accuracy.
Can you talk about the timeline of an aneurysm and when the different cytokines become apparent?
Yeah, so that only really, aneurysms being guided by an inflammatory process was recently discovered probably 5 years ago, and our group was one of the leading groups to discover that. So it hasn't really been studied well about the different aneurysm profiles. But what we can say from our preliminary studies with acute, chronic, and impending rupture is based on your risk factors and age and other demographics. An acute aneurysm is probably 1 to 2 years after you've been diagnosed or are found to have the aneurysm. And then it can range from probably 3 to 5 years of growth, maybe even longer. And then impending rupture is largely variable.
You said go ahead, Alana. Go ahead. I think you said that you can eliminate the risk of rupture in your pitch, and just how is that really possible? I mean, you had the skulls along that pathway, and obviously there's so many risks there with the gaps. But you're saying that you can test frequently enough that it'll say you have to go to the hospital now because you're pre-rupture, and then they can basically intervene at that point in an invasive way or some other way to prevent rupture.
Yes. So when rupture occurs, when the aneurysm grows and then ultimately pops, right? What we foresee this test being is our risk of rupture metric is a percentage almost. And clinically, once this test is used and validated by the scientific community, let's say an 80% risk of rupture is when you have to intervene. So because of the price point of this test and ease of this test, you'd be able to probably do this test maybe like once a month for a patient that's in the watchful waiting period and accurately predict when they're going to reach that 80% time point and then clip it or coil it right before then, preventing rupture.
Did I understand you correctly that the cost is $70? Is that what you charge the patient? And then the total market, if you applied this to all the people that are in that watchful waiting period in the U.S., is $63 million a year. Did I hear that right?
No, that's so the cost of goods for the CAT-7 test is $70. So that's how much it costs to produce it. Analogous blood tests that we found through Medicare reimbursement reimburses $770 for that test. Therefore, the minimum baseline that we could charge is $770. And we also demonstrate considerable improvements compared to the standard of care. Therefore, we'd also be justified in increasing our cost and increasing reimbursement for this test.
And did you say then that the total market size would be $63 million a year?
Yes, for the symptomatic cohort, and then around 45 if we expand to a one-time screen of family members.
So when you look at the FDA approval, could you talk a little bit more about that? Exactly what's in the clinical trials, et cetera, what the cost would be overall, and then the motivation, which is always fascinating to me within a healthcare, between the hospitals, the insurance companies, the reimbursements, et cetera.
Right. So we would pursue 510K accelerated approval as we believe this device would be a breakthrough technology for the price point, and then improvements in mortality and morbidity. So that is FDA approval. Regarding insurance, this would likely be reimbursed because we'd be able to detect aneurysms before they rupture, reduce the occurrence of rupture, which would decrease costs. Hospitals would likely pay for this as well because people on their insurance plans would like to reduce costs for those people who take the hospital insurance plans. So therefore, they would reimburse that test. And then physicians is probably the area that we're most concerned about. Neurosurgeons are very stubborn, and they're very stubborn with the technology that they use, the way they were trained. And based on those methods, we hope that it would be adopted. And with a large training center like UPMC and developing this test at UPMC, we believe that it will be.
Because this is, published science, I mean, is it defensible? Are there other teams working on this test, and is it sort of a race, or what does competition look like?
That's a great question. I wish I had time to include this in my presentation. We have one direct competitor, which is Neurovascular Diagnostics in the gray box. They're out of the University of Buffalo. Their test hasn't reached the market yet, and it's an mRNA-based test. Therefore, they were placed higher on the affordability scale because it's more expensive to store their samples, and lower on the accuracy scale because our preliminary studies have essentially invalidated their method of testing, which is why we shifted from mRNA to analyzing proteins, or these cytokine markers. Our direct competitor is, again, the standard of care. All right, thank you.